Pathogenesis of lupus nephritis. Introduction. Lupus nephritis, LN, is one of the most serious manifestations of systemic lupus erythematosus, SLE, occurring in up to 60% of SLE patients, particularly affecting young women of childbearing age. It is a major cause of morbidity and mortality in lupus patients. LN represents the renal manifestation of systemic autoimmunity, characterized by the deposition of immune complexes and the activation of inflammatory and fibrotic pathways in the kidney. Understanding the pathogenesis of LN is crucial for guiding therapeutic strategies. 1. Genetic susceptibility. Several genetic factors increase susceptibility to both SLE and LN. HLA genes, particularly HLA-DR2 and HLA-DR3, are strongly associated with SLE and LN. Complement deficiencies. C1q, C2, and C4 deficiencies impair clearance of immune complexes and apoptotic debris, promoting autoimmunity. Polymorphisms in genes related to immune regulation, such as IRF5, TAT4, PTPN2D3, FCGR2A, and FCGR3A, receptors for IgG. APO1 variants, associated with increased risk and severity of LN, particularly in individuals of African descent. 2. Loss of immune tolerance and autoantibody production. The central event in SLE pathogenesis is a breakdown in self-tolerance. Aberrant apoptosis leads to increased release of nuclear antigens, DNA histones, ribonucleoproteins. Defective clearance of apoptotic bodies results in chronic exposure to autoantigens. Autoantibodies, especially anti-dsDNA and anti-SEM, are generated by autoreactive B cells. These antibodies form circulating immune complexes or directly bind to glomerular antigens. 3. Role of immune complex deposition. Immune complexes, ICs, are key mediators in LN pathogenesis. Deposition in glomeruli, mesangial, subendothelial, subepithelial, leads to complement activation and inflammation. Anti-dsDNA antibodies can also bind directly to glomerular structures, e.g. laminin, alpha-actinin, annexin 2. Neutrophil extracellular traps, nets, and chromatin fragments provide autoantigenic material that promotes IC formation. 4. Complement activation. The classical complement pathway is activated by immune complexes. Activation leads to generation of C3A, C5A, anaphylatoxins, and the membrane attack complex MAC, all contributing to glomerular injury. Complement split products, C3d, C5b9, are commonly found in renal biopsies. Complement consumption, low serum C3-C4, correlates with disease activity. 5. Cellular immunity and renal infiltration. A. T cells, CD4 plus T helper cells, Th1, Th17, enhance B cell autoantibody production and cytokine release. T follicular helper, AF cells, promote germinal center reactions and B cell maturation. Cytotoxic CD8 plus T cells and double negative T cells, CD4, CD8, may contribute to renal damage. B. B cells and plasma cells. B cells not only produce autoantibodies but also present antigens and secrete pro-inflammatory cytokines. Long-lived plasma cells in kidneys may sustain chronic inflammation despite immunosuppression. C. Innate immune cells. Dendritic cells, DCs, especially plasmacytoid DCs, produce high levels of type 1 interferons, IFNA, a hallmark cytokine in SLE. Macrophages and monocytes infiltrate the kidneys and contribute to tissue damage through cytokine secretion and phagocytosis. 6. Role of cytokines and chemokines. Several cytokines are elevated in LN and contribute to inflammation and tissue injury. Type 1 interferons, IFNA, IFN-beta, promote dendritic cell activation and B cell differentiation. TNF-α, IL-6, IL-17, IL-23 enhance recruitment of inflammatory cells. BAFF, B cell activating factor, promotes B cell survival and autoantibody production. MCP1, CCL2, and CXCL10 recruit monocytes and T cells to inflamed glomeruli. 7. Tubulo-interstitial involvement. Although glomerular inflammation is the hallmark, the tubulo-interstitial compartment plays a critical role in disease progression. Tubulo-interstitial inflammation and fibrosis correlate better with long-term renal outcome than glomerular lesions. Local immune complex deposition, hypoxia, and epithelial to mesenchymal transition, EMT, of tubular cells contribute to fibrosis. 8. Epigenetic and environmental triggers. DNA methylation defects, histone modifications, and non-coding RNAs, e.g. miRNAs, modulate gene expression in immune cells and may contribute to disease flares. Ultraviolet light infections, e.g., EBV, and certain drugs can trigger flares or disease onset. 9. Classification and pathologic correlates. The ISN-RPS classification of LN reflects underlying pathogenic processes. Class 2, mesangial IC deposition, mild. Class 3-4, subendothelial IC deposition, proliferative LN, severe inflammation. Class V, subepithelial deposition, membranous LN, nephrotic range proteinuria. Class cysts, advanced sclerotic LN, irreversible damage. Immunofluorescence shows full house staining, IgG, IgA, IgM-C3, C1q, supporting the immune complex-mediated pathogenesis. Conclusion: lupus nephritis is a multifaceted disorder driven by genetic predisposition, loss of immune tolerance, immune complex formation, and dysregulated innate and adaptive immune responses. The interplay of humoral and cellular immune mechanisms leads to renal inflammation, tissue injury, and, if unchecked, fibrosis and renal failure. Understanding these mechanisms provides the foundation for targeted therapies, such as B-cell depletion, interferon blockade, and complement inhibition, which aim to modulate specific steps in this complex pathogenic cascade.